So we're going to show some surface anatomy here. So this is the notch on the top. Right in front of this mark here is the ACJ, posterolateral corner. I've just kind of described the footprint of the supraspinatus, but let's come around the front because we're talking here today mainly about the biceps. So biceps has the long head, which goes up. If you feel the corner here, it normally comes all along here. In front of the biceps, or kind of superior to it, is the anterior leading edge of the supraspinatus. And then your subscapularis sits here. So this is subscapularis, this is supraspinatus, and there is the bicep which goes up. There's a little funny turn here, like a 90-degree turn here, and there are structures called the biceps pulleys that keep the biceps in that place, because this is an abnormal turn, right? Now that's the long head. The short head comes from the coracoid, so you'll have one head here, and that's your two heads of the biceps. So we're going to concentrate a little bit more on the short head today. So if you look at the short head, why is it that it goes up like that and then does a little turn and keeps it there? Because clearly there's a lot of risk with it doing this little 90-degree turn, because quite often in young people, if you're a gym bunny and so on, your biceps pulley, i.e. the structures that keep the biceps in place, can actually tear. So normal biceps glides up and down, but these pulleys tear. What will happen is that it'll either go that way or it'll go up that way. So I'll go this way or I'll go that way. And as you can clearly see, the risk at that stage is that the biceps, which is a nice strong tendon, can actually injure the subscapularis or can injure the supraspinatus on top. So quite often in young people, the biceps is a problem if the pulley tears. And that pulley tear can cause damage to the supraspinatus up here or the subscapularis down here. It's a very, very difficult thing to notice. Quite often with a biceps pulley lesion, you may not see anything in the supraspinatus apart from a little partial tear, but the history and the examination is key to tell us if this is going to be an issue or not. Now, people often ask, why is a biceps funny shaped like that? Why does it do a 90-degree turn? But actually, in most animals that we've evolved from, it doesn't, because if you're a bird, your arm is right up here, and the biceps is pretty much a straight line. Or if you are a animal that walks on your hands, right, then again it's very much a straight line. So having something down by the side is very much a human thing. Even monkeys and chimpanzees have their arms up here most of the time.
Description of the anatomy, we're going to consider how to assess the biceps tendon. And as Ali alluded to a moment ago, you don't necessarily assess the biceps tendon itself, you assess the functionality of the entire shoulder and the functionality of where the biceps lives, because very rarely will you actually find that the biceps tendon itself is a true source and true cause of the pain. Tendinopathy only accounts for 5% of biceps pain rather than anything else in particular. So what's the first thing you do when you're assessing the biceps tendon or the shoulder at large is you speak to the patient. You consider the internal and external risk factors around that patient. Age, work history, sporting history, mechanism of injury is extremely important. Once you've determined that, you may begin to categorize what this problem could be. So for example, is it a degenerative issue because you have an elderly patient who's used their shoulder quite heavily throughout their lifetime, with a degenerative cuff tear leading the biceps tendon to be chronically overloaded? Do you have a tendinopathy? As I say, accounts for only approximately 5%, but they will say that I moved house recently or I started taking up a new racket sport recently, and that could be your hint towards tendinopathy. Or do you actually have an injury to the rotator cuff, such as the leading edges as Ali and the pulleys as Ali alluded to? Is there an injury to those resulting in overusage of the bicep tendon and the cause of its pain? Yeah. So that's the first thing you can do when getting into.
And that's quite an important point. And the take-home message from that is that talking to the patient and finding out these details probably gives you 50-60% of the information.
Absolutely.
Right? And that's the key here. An examination does most of it. MRI scans and so on are just a little bit on the icing on the top.
Yeah, and with regards to, and you can tell me what you think about this one, there's some controversy with regards to which imaging modality is actually the gold standard, or which investigation method is the gold standard. They even say arthroscopy is not necessarily the gold standard because you can't visualize right the way down the full.
Correct, and you can't see within the tendons. You can't see tendinopathies quite well. And I guess my take on that is I get most of my information from the history.
Yeah.
a lot from the examination, and then you're left with that little 10%, right? And it's very patient specific, right? So if I'm suspecting a more deeper issue like a slap tear, etc., then I might do an MRI scan. But if you have a biceps pulley lesion, then sometimes you may need to do a dynamic exam like an ultrasound scan to see if it's flipping in and out.
Yeah, and that's what a lot of people actually tend to go for is an ultrasound scan, because it's cheap and easy initially, gives you a dynamic image, and it may help you begin to decide if you need to go for MRI or further forms of investigation.
Correct.
So the actual physical examination itself, you've already formulated some hypotheses in your mind. This physical examination helps you include or exclude those thoughts. So with the arm by the side, one of the first things you're going to do is simply look at the patient. Do they have a very poor posture? Were they sitting poorly in the waiting room? Is that a reflection of how they spend much of their day? So analysing the patient's posture and the times that the patients spend in these postures is extremely important, because there is no bad posture, there's just a posture you spend too much time in. So Sarah stands very well. She doesn't have particularly protracted shoulders or a particularly kyphosed thoracic spine, for example. A little trick is which way are their thumbs pointing. Sometimes you'll see patients standing there with very internally rotated thumbs. Have a think about what that actually does to the arm higher up. So a little small tip can be, when you're walking, have your thumbs point towards the direction you want to walk in. And that externally rotates the humerus and really takes some pressure off the biceps tendon right there straight away. With regards to physical examination, you're going to look at the movement of the shoulder. So if you have both arms there in front and above you, as high as you can go, and repeat that several times. You're going to stand to the side, view that several times over, observing for quality of movement, any clicking or clunking that may be obvious, any moments of pauses or moments of pain that she reports. And you're looking at scapular dynamics as well, because you can have scapular dyskinesis, which may have an effect on the biceps tendon.
And symmetry is so important here, isn't it?
Essential,
yeah.
Absolutely.
Perfect.
But asymmetry might not necessarily mean the presence of anything wrong. Asymmetry is just an observation. You need to determine if that asymmetry is a driver of your problem.
Correct.
You're going to view from the front, from the side, and from the rear, and have the person do repeated movements. Okay. One of the other repeated movements is abduction. And you can really, this can be quite telling, because when you get above 90 degrees, you're beginning to influence the space where the biceps has to operate and has to live. So you might see people judder, you might see people shake, you might see people simply pause and not be able to move any further.
Correct, perfect.
Great. So when we get around to the front, considering the anatomy markings that we already have, we're going to palpate the biceps tendon, okay? And get in nice and deep, feel it flick underneath your finger, and ask the patient if that's painful. Because if that is painful, that's very indicative of the idea that the bicep tendon itself may be a source of your pain, or very close surrounding structures. It's actually a remarkably sensitive test to do. Some of the other tests you can do would be O'Brien's. So O'Brien's is
one of my favorite tests.
It's a very good test, yeah.
But as you can tell, that with O'Brien's, you'll demonstrate it now. It is a compression test, not just of the biceps, but a lot of structures around it.
Absolutely.
So you're led by the history, the age, etc. But O'Brien's can cause pain over the ACJ, can cause along the biceps at the pulley or at the slap level, can be a problem with the anterior cuff. Where the pain refers to when you're doing O'Brien's, I find it is quite actually useful.
Very.
Right. So would you mind demonstrating that?
Yeah, sure. So with O'Brien's, you're going to ask the patient to flex their arm up to 90 degrees with 15 degrees abduction, and you're going to internally rotate the arm, okay? And you're going to ask the patient to add resistance here, and you're looking for the presence of pain. So it's I believe 61% sensitive and 84% specific.
Yeah.
So sensitivity, not great, somewhat sensitive, but sensitive to what? Because the response is you're looking for pain, but as you just alluded to, you need to delve into that response a little bit more.
Yeah.
Where is the location of your pain? So if
you have the arm in that position again, now what's interesting that I find is that, again, not always sensitive, but a lot of times when you have pain on O'Brien's across here, is usually cuff-related pain. If you have pain along the line of the biceps, or even sometimes in the posterior joint line, it may suggest a biceps lesion or a biceps connecting to the posterior labrum. See, O'Brien's can also cause if you push hard enough, pain from a posterior labrum tear.
Absolutely, yeah.
And that's referred exactly at the back as well. But again, when you do O'Brien's, you call compression of the AC joint as well.
Yeah.
So where they notice a pain actually helps me figure out a little bit why the O'Brien's is positive.
Yeah, so O'Brien's is a very important test. One of the other commonly used tests for biceps specifically is Biceps Log 2 test.
Yeah.
So this is usually done with the patient lying down, but just for the purposes of today, it's abduction up to 120 degrees, okay, supination of the wrist, and it's a resisted elbow flexion.
Yeah.
So resisted elbow flexion. And if the patient says that their pain is generated along the length of the biceps tendon, that's quite indicative of the idea that you may have pain source from the biceps tendon itself. But it's very easy to mix this up with possible slap tears as well.
Yeah, and again, it goes back to the history as well. If a patient is a overhead athlete, or a patient is in the gym and they felt I was doing something and something just went snap, you know that's probably a mechanical problem. Whereas if they were just doing a lot of biceps curls and 2 days later the biceps was a bit sore, you're probably thinking more of tendinitis stuff, right? So the take-home message is, we get used to this, but the algorithms that our brains make in our head depend a lot on the history.
The history is really essential.
Yeah.
With the biceps load test, there's a very low sensitivity of about 30%, but it is more specific to the biceps tendon itself. Other things you can do are a speeds test, for example, which, when you think about it, isn't really too dissimilar to the O'Brien's test. So
Correct.
if you think about the O'Brien's test for a moment, it was in this position.
Correct.
A modification to the O'Brien's test is into supination and asked to repeat the movement. And if you do get a repetition of pain here, with the supination, you're compressing the subacromial structures a little bit less, so it may guide your thinking. Speeds test in this position, resistance in supinated, and flex your shoulder up to 90, your shoulder itself. So that's it, yeah. And resist here, and there's your resistance.
Yeah.
You're trying to load the biceps. So those little small nuances to testing can help guide your thought process.
Yeah, exactly. And again, loading the biceps by itself is quite hard. And you're probably loading the biceps and maybe the surrounding structures at the level of the rotator interval. With the difference between O'Brien meaning that you cause some active compression as well.
Exactly.
With speeds, you probably don't cause the compression. Very similar to when you do Burkhead's thumbs up and thumbs down. When you do down, yes, it may be a little bit more posterior cuff, but what you're actually doing is rolling your greater tuberosity and decreasing the space and causing more impingement as well.
But there's many structures there, so it's hard to be sensitive, isn't it?
Correct.
You're impinging many structures.
Correct.
Joe Gibson, a friend of mine and yours, says...
We love Joe, yes.
We do. She says, poke it, compress it, and load it. And I think that's a nice little trio of things to do, a sort of mini clustering of trio of things to do to the biceps tendon to see if you can generate pain from that structure.
Brilliant.
Once you've looked closely at the shoulder, you need to take a further step back again. We did look at posture and some general movements, but if this is an overhead athlete saying that I'm a tennis player and I get pain 20 minutes into play, you're probably not going to generate their pain here. You're going to actually have to load that patient up in a way that is similar to their task, to the point of where the pain begins to occur, and then observe what they do.
Correct, yeah.
Do they have sufficient glenohumeral joint range of motion into all directions? Do they present with a girder or geared? Yeah. And what are you going to do about it? Is it actually normal for them because they're a throwing or an overhead athlete?
And that's quite an important point as well. Sometimes, if you have lack of internal rotation, you may have a very posterior tight capsule, and that may actually push your humeral head forward and result in secondary biceps pain.
Exactly,
in the front.
And that's actually quite common too in your athletes.
Correct.
So once again, if we just demonstrate that, if you're a throwing athlete, you'll be quite tight posteriorly. So what you'll see is a forward shift of the humeral head compressing the biceps tendon. Now, if you can imagine, you're repeatedly throwing, repeatedly abutting against the biceps tendon. That can be the source of your pain and discomfort. Now, some manual therapy can be really useful there, and having the patient do some stretches, such as say sleeper stretch and whatnot. But more importantly, have you assessed the thoracic spine also as well? If the thoracic spine does not have the ability to rotate, so if you cross your arms across your body, Sarah, I would do this in seating to take the legs out of it, and ask Sarah to rotate one direction versus the other, and see if there's any rotational deficits in the thoracic spine. What does a throwing athlete do? As I often joke, you don't see Roger Federer serve a tennis ball like this. He uses his entire body.
Correct.
And if we don't have the ability to rotate through our thoracic spine, use our hips, be able to control our kinetic chain right the way from the ground all the way through to the hand where the energy is exiting, something is going to be overworked, and you often find that is the shoulder. So if someone is rotationally stiff in the thoracic spine, for example, they will try and rotate more through the shoulder to have a greater arc of movement to generate power.
Correct.
So you must take a step back and look at their task, fatigue them, and then see what they do in order to see if you can expose the true driver behind their problem. Because as we said, it's very often not the biceps tendon itself, it's how the biceps tendon is being treated.
Correct. So biceps is often a problem because it's been mistreated by other people.
Yeah.
And then the biceps itself mistreats the rotator cuff.
Absolutely.
So there's always a war going on between the biceps and the other structures.